Good afternoon, everyone. I'm Naifa Busaidy, one of the endocrinologists at MD Anderson Cancer Center, and thank you to the ThyCa Program Committee for inviting me today. It is my honor to talk about one of my favorite diseases. I am passionate about thyroid cancer, and today I'd like to share with you what targeted therapies are, including radioactive iodine, and what some of the side effects are and how we manage them. Very important to be aggressive about management of thyroid cancer and its treatment so that we can help patients tolerate therapies better. So before I start, I'd like to share with you my financial disclosures. I get grant funding, which means I get money to conduct a clinical trial or a drug that's in research from Bayer and from GlaxoSmithKline, and I will be discussing investigational therapies or therapies that are not FDA approved for thyroid cancer, as well as off-label uses, meaning drugs that are FDA approved for something else and we're evaluating it in thyroid cancer. So with that, I'd like to start with some background information about thyroid cancer. So thyroid cancer is very common. There's at least 60,000 new cases in the United States this year alone, but the prevalence, meaning the number of people who have thyroid cancer living with it, not newly diagnosed, is over 400,000. Women make up about 3/4 of them and make up about 5% of the female thyroid cancer survivors. So when we talk about thyroid cancer, most of you already know this, there's 4 types of thyroid cancer. Papillary and follicular thyroid cancer make up the vast majority, and together throughout the talk I'm going to be calling them differentiated thyroid cancer. Anaplastic and medullary thyroid carcinoma are also included, but are much more rare. And we'll briefly talk about medullary thyroid cancer because there's 2 drugs that are FDA approved for that indication. So thyroid cancer is one of the few cancers that's still rising in incidence or increasing, and it's unclear why that's occurring. So various people have looked at this and said, well, maybe it's just because we have better ultrasound or better CTs, and so we're picking up more thyroid cancers. And what they found is that in various studies, there's actually an increase in larger tumors as well. So we're not just picking up smaller cancers with better technology, but there's also an increase in the larger tumors. A lot of controversy about that. And thyroid cancer is going to be more and more common, especially in women, over the next decade. It's the 5th most common cancer in women, so we keep calling it a rare cancer, but when you make the top 5, you're no longer rare. So these are really good set websites or for guidelines. The National Cancer Comprehensive Network has specific thyroid cancer guidelines, and the American Thyroid Association has another set of great guidelines. The American Thyroid Association guidelines are going to be updated probably in the next month or so. So the standard therapies for differentiated thyroid cancer include surgery, radioactive iodine, and sometimes more surgery and more radioactive iodine. And the third prong of that is thyroid hormone suppression, or giving back the patient thyroid hormone and a little more than the body needs to keep the cancer from coming back. With medullary thyroid cancer, surgery is the best treatment that we have. Sometimes we give these patients radiation, and we give them back thyroid hormone because we remove their thyroid, but this time we keep the TSH or the thyroid hormone levels in the normal range. We don't give them a little more than the body needs because it's not anti-cancer for medullary. So to tell somebody they don't have any evidence of disease, if they have differentiated thyroid cancer, their thyroglobulin, the tumor marker, and antibody should be undetectable. The ultrasound of the neck should show that they don't have any disease. And for medullary thyroid cancer, to say they don't have any evidence of disease, they also should not have any disease in the neck, but their calcitonin and CEA are their markers and should be undetectable to tell them that they don't have any evidence of disease. 85% of patients will be cured in the case of differentiated thyroid cancer with surgery and plus or minus radioactive iodine. So when we talk about people who need further treatments, we're talking about 5 to 15% of the population of patients with thyroid cancer. So what do we mean by these? Who are these people with metastatic disease? So about 15 to 20% of these patients with thyroid cancer, their cancer will come back. And most often Cancer does not take up radioactive iodine. With differentiated thyroid cancer, a lot of times when the disease comes back in the neck, people try to look with a whole body scan and see if we can treat with more radioactive iodine, but very often it doesn't take up iodine. But people keep using radioactive iodine because that was the only tool we had for a long time. And we end up causing a lot of side effects and harm in patients when we actually did not help them. So it was very important we moved forward in the research field to find other treatments. So about 5% of cancers will spread to distant sites, meaning outside of the neck. About 15 to 20 will be in the neck. This is just a slide to show that patients who have what's called stage 4 disease, meaning more advanced disease, depends on the size of your tumor, whether you have disease in your lymph nodes, whether you're over age 45 or not. So if you have the highest stage, which is stage 4, then you do have a higher risk of death or recurrence of your disease. And then patients who have thyroid cancer that's spread to their lungs that does not take up radioactive iodine have a shorter survival, meaning they do worse from their thyroid cancer. So this is just a picture to show you when patients have thyroid cancer in their lungs. On the right here, this is half a body. The head is here, shoulders, and the neck, and these are the shape of one's lungs. The chest x-ray has lots of dots showing the thyroid cancer. The radioactive iodine scan is lighting up, showing that this patient has thyroid cancer in their lungs, but it does take up radioactive iodine. So this is somebody you do want to use more than one treatment of radioactive iodine in. This patient, again, you can see the shape of the body here, and there's just a little bit of radioactive iodine uptake, or the black, in the neck. But their CT scan, the black is good, the white dots are the thyroid cancer. So they take a cut through your body if you're lying flat, and the white dots are the thyroid cancer. But the radioactive iodine scan did not light up. So we know they have cancer because we have it showing on the CT scan, but we don't see it light up on the radioactive iodine scan. So we call these patients radioactive iodine negative, or their thyroid cancer, not the patients. The thyroid cancer is radioactive iodine non-avid or negative. So how do we treat these patients? Well, before 5 years ago, we used to tell patients that, we're not even close to a race for the cure. There's not even a race for it. So it was unfortunate. But thankfully, now we've come a long way. And so what do the guidelines say? Well, the American Thyroid Association guidelines, as well as the National Cancer Comprehensive Network guidelines, say that the patients who have metastatic disease that's either slowly growing or stable, and it's not causing symptoms, we just need to give them a little more thyroid hormone than their body needs and observe them. And in medullary thyroid cancer, we just observe them as well, but we don't give them extra thyroid hormone because it doesn't help them. But for patients who have thyroid cancer that every time they come back it's growing, that's called progressive metastatic disease. And in those patients, we do need to act and give them some sort of treatment. They say that we should offer clinical trials or drugs that in theory should work, or we have hope that they would work in thyroid cancer first. And then we can also offer them various kinds of what's called small molecule kinase inhibitors, which we'll talk about. Yeah.
What do you mean by symptomatic? What are the symptoms that you look for?
Yeah, so very good question, because most thyroid cancer, so the question was, what do we mean by symptomatic disease, or patients with thyroid cancer who have symptoms from their cancer? So most patients with thyroid cancer don't have symptoms. They don't even know that the disease is there, which is a good thing, until they see the doctor and pictures or different images are taken and the disease is seen there. So it's the small percent of patients that do have symptoms, because you can get a lot of thyroid cancer in your lungs before you have any symptoms. You can be almost full. The lungs are very compliant. So there's lots of space and workarounds. So if you have a lot of disease in your neck, you can have pressure. It could be swallowing problems or breathing problems if it's pushing on your breathing pipe. If it's in your bones, you can have bone pain. And if you have fluid around your lungs, what's called pleural metastasis, you can be short of breath, or a lot of lung metastases. It's closer to the end when patients start losing weight from their thyroid cancer, so very different from the typical cancer. So when people talk about chemotherapy, most people think about traditional chemotherapy, or what's called cytotoxic chemotherapy. So the way this works is you use a chemical to kill the cancer, and it usually works by killing quickly cells that are dividing quickly. Okay, It's not necessarily targeting a specific type of cancer cell or a specific type of protein or gene on the cancer. So there's been a few studies that have looked at chemotherapy, or what we call traditional cytotoxic chemotherapy in thyroid cancer, and there were a few people who had some shrinkage in their tumor, but it wasn't very exciting. But because about 20 to 25% of patients would show what's called a partial response or shrinkage in their tumors, doxorubicin got FDA approved for thyroid cancer many years ago. And doxorubicin is a cytotoxic chemotherapy. But this is the long list of chemotherapies that have proven to prolong survival or lengthen a patient's life. So we clearly needed better drugs. There's nothing on that on purpose. Okay. So for medullary thyroid cancer, we're going to talk about the top two drugs later. But cytotoxic chemotherapy was not very effective, but there are various regimens or combinations of drugs that have been tried. So let's talk a little bit about targeted therapies and what we mean. So targeted therapies are medications that interfere with parts of the cancer that promote its growth or help the cancer survive. And small molecules are just different types of drugs, of targeted therapies that can kill these cells. Often you'll hear these drugs end in MIB or IB or AB, and those are the type of drugs we're talking about. So what's the difference between chemotherapy and targeted therapy? Well, targeted therapies are types of chemotherapy, but they're not what you would traditionally think about chemotherapy. They're not cytotoxic chemotherapy. They're more specific to the cancer cells, and they don't simply interfere with rapidly dividing cells. They actually try to harm the cancer with less effects on the normal cells. They try to find what in this, not they don't actually try to find, if we know what is actually making the thyroid cancer grow, those are called etiologic mutations, what's causing the cancer. And so these targeted therapies try to attack that. And whatever's feeding the cancer, the blood vessels and the oxygen, it tries to attack the surrounding or the environment. So the original targeted therapy is radioactive iodine, right? The thyroid cancer, you have something, radioactive iodine is specific to thyroid cancer. It doesn't treat other cancers. So it's great. So for thyroid cancer, we actually started way ahead of the game. And then in the last 10 years, everybody's gotten excited about targeted therapies. Well, we had this a long time ago. But unfortunately, for patients when the cancer spreads, a lot of times this doesn't work. And this was a paper from many decades ago saying, when they were excited that radioactive iodine after 4 treatments actually cured the first person with thyroid cancer. So what are the goals of radioactive iodine therapy? Radioactive iodine therapy is, the reason it's given initially is to decrease the chance of the thyroid cancer coming back and potentially decrease the risk of death. But many thyroid cancer patients aren't at risk for death. So the question is, who actually needs radioactive iodine? And remembering our goals, who are we actually helping? So let's talk a little bit about the side effects of our first targeted therapy, radioactive iodine. It's for most patients, when you need a low dose of radioactive iodine and you need 1 treatment, it's actually fairly safe. But interesting research has come out in terms of what it can do. So patients who have thyroid cancer that's in the lungs that take up radioactive iodine, you can get something called pulmonary fibrosis, which is scarring of the lungs. You can get a dry mouth and what's called xerostomia, which may sound like it's simple. It's not. That affects your quality of life. You can't eat bread without drinking water all the time. You can't talk. You get cavities. Your throat dries out. So it affects patients' quality of life. And then you get increased risk of cavities because right off the bat, bang, you lose at least 30% of your saliva. You can tears still come out, but you can block the duct where the tears go back in, called nasolacrimal duct obstruction. Thankfully, there is a surgery that can be done to open that up. But again, there are side effects that people don't necessarily connect to radioactive iodine, but are known causes. And then secondary cancers I'll show you in a little more detail. And your blood counts can go down, and in males, you can have decreased sperm. So there's been the best known study for showing whether radioactive iodine does increase the risk of secondary cancers was showed a couple of cancer increased risk of a couple of cancers. So why would this come up? When you take that radioactive iodine scan in patients, you'll see uptake maybe a little bit in the thyroid bed, which is expected, where you had recently had surgery. But then you also see some radioactive iodine uptake in the salivary glands, in the bladder, and in the stomach and the gut. And so people have, and sometimes, especially in young women, you'll see it in the breast. So people have asked, well, is this radioactive iodine going to cause breast cancer and bladder cancer and stomach cancer and salivary gland cancers? And so most of the studies have suggested, well, if you get multiple doses of radioactive iodine at high doses, that you do have an increased risk of leukemia. But if you're just getting 1 or 2 doses, you may actually be okay. So Dr. ThyCa actually sat down and did a really nice study and looked at this to see whether we do have an increased risk of other cancers. And she's done, there's several people who have done several studies. She's done one of the better studies out there. And she showed that there was an increased risk, a slightly increased risk overall of other cancers, but leukemia was the one that was most associated with this. There was another study that looked at patients with stage 1 disease, okay? So they just have the cancer in the thyroid, not in the lymph nodes. Most of us today don't give those patients radioactive iodine. But everybody, anytime you had thyroid cancer before, everybody was getting radioactive iodine. So this study looked at those low-risk patients, meaning those who are probably at low chance of dying from their disease and a low chance of this cancer coming back, which were the goals of the radioactive iodine, right? To decrease the risk of the cancer coming back and decrease your risk of death. But these patients received radioactive iodine, and they found that the younger patients who received the radioactive iodine with low-stage cancer did have an increased risk, or it was associated with an increased risk of salivary gland cancers and leukemia. So again, none of these studies can prove cause and effect. So we're not going to walk out of here and say radioactive iodine is causing cancers, but there is an association. So either those people had some sort of genetic predisposition, and then you give them radioactive iodine, and then and they got an increased risk, or it was, it looks like it's more than a coincidence, or they were going to get it anyway and you can't tell. Right? So this is not a study that was looked at to try to prove whether radioactive iodine causes cancer or not. It's very important that we take that home. So most of you have probably seen this slide from Dr. Mike Tuttle, one of the endocrinologists at Memorial Sloan Kettering, who's a thyroid cancer guru. And he shows this slide. He goes around the country saying less is better. And so, we should probably start thinking about lower doses of radioactive iodine, or in some cases, no radioactive iodine. And so traditionally, we used to give everybody, if you have a diagnosis of thyroid cancer after surgery, everybody got radioactive iodine. And now we're taking a little bit of a not a backwards approach, a more directed approach to try to see who really needs it, and our goal is first do no harm. And so thinking about this, there's more and more data coming out that patients with stage 1 disease or early disease may not benefit from radioactive iodine, because if your risk of the cancer coming back is low, and the goal of radioactive iodine is to lower that risk, then maybe we're not helping you by giving you radioactive iodine. So this is just a picture to show you with the radioactive iodine, again, the whole body. This is only showing half the body. And there's uptake in the thyroid bed only. And this was that salivary gland uptake that we were talking about. That's called physiologic. It doesn't mean they have cancer in their head. So that's radioactive iodine. What are other types of targeted therapies? So there's various different classes of targeted therapies that some have been looked at in thyroid cancers and others have not. There's something called enzyme inhibitors that inhibits the proteins that signal the cancer to grow. They can help induce death on the cancer cell. And then there's anti-angiogenic drugs, or angiogenic inhibitors. And angiogenesis just means increasing blood vessel growth, and blood vessels feed the tumor. So this is the most common type of drug that has been looked at in thyroid cancers. They're called anti-angiogenic drugs. They starve the tumor of its blood supply and try to decrease the growth to the cancer. You also hear the word being thrown around called tyrosine kinase inhibitors. And so what is that? Well, that's a type of targeted therapy that inhibits the activation of this part of the cell that signals or sends a signal to the cancer cell to grow. So we want to tell that signal to the cancer cell to stop growing. We also call them small molecule inhibitors or monoclonal antibodies. The small molecule inhibitors tend to end in IB, IBS, and the monoclonal antibodies tend to end in AB, AB. And so this is just a picture on the left of monoclonal antibodies and on the right of the small molecule tyrosine kinase inhibitors. And so there's a lot of abnormal proteins that make cancer grow, and it becomes like an alphabet soup. So many different cancers have many different signaling, and we're basically just at the tip of the iceberg in trying to figure this out in both thyroid cancer and in many other cancers. So you'll see schematics sometimes on Wikipedia or in these books, papers when you're reading them. If you have a cancer cell, you have the receptor, the receiving end, and then some growth factor that goes to this receptor and tells the cancer cell to grow. And the job of your drug is to stop this from happening. It either goes in here instead of this, or it somehow stops this from working. There's various ways that pharmaceutical companies are trying to figure out how can these drugs work better. So this is a slide I took from Dr. Steve Sherman, but we have to understand what are the pathways that are abnormal in thyroid cancer, and we've found a few of them, but we're not sure if they're the cause of the cancer or they just happen to be increased in cancer, and more research is being done to figure some of that out. So some of the pathways you'll hear about are the RAF pathway, RAF, and you can have patients that have the gene called BRAF that's abnormal in papillary thyroid carcinoma. RAS, PI3 kinase, AKT, and RET-PTC are common ones that we see in papillary thyroid cancer and probably explain about 75% of thyroid cancers. This is just another schematic showing you, this is inside a cell here, and these are some of the signaling pathways that normally help survival and the cell to divide and grow, and they, if they're what's called upregulated or if they're increased, then the cancer cell says I need to grow more. So our job is to, all of our jobs, is to try to find drugs that attack those. Does that make sense? So these are just some of the drugs that attack some of those areas. Some of these abnormal signals, or these what's called mutations, are prognostic, meaning if a patient's tumor has that abnormal gene, that it tells you that their cancer is you can predict that their cancer may grow fast or may spread, and some of them are just present and you don't know if necessarily they're going to do any worse. So anti-angiogenic drugs, again, are the drugs that starve the tumor of its blood supply, and they attack the vascular endothelial growth factor. So you'll hear people saying it's due to the VEGF inhibition. That's just the vascular endothelial growth factor. That means the growth factors to the blood vessels are being inhibited or stopped by the drug. And so when you look, and this is again another slide I took from Dr. Stephen Sherman, my boss. When you look at signaling pathways that help thyroid cancer grow, these are the ones on the left that we showed earlier. The ones on the right is endothelial cells in a blood vessel. So this is just showing you that the blood vessels feeding the tumor, these all talk to each other. So the proteins that are abnormal in the cancer can signal and tell the blood vessel, give me more blood. I love blood. So they talk to each other and help each other grow. So with that, there are 3 drugs FDA approved in thyroid cancer. So I'm going to very briefly show you what they are. Sorafenib is FDA approved for differentiated thyroid cancer, so papillary and follicular thyroid cancer that is progressing or that is growing. So it's not for everybody who has papillary thyroid cancer or follicular thyroid cancer. It is for patients who have disease that does not take up radioactive iodine that is growing despite giving you more thyroid hormone than your body needs. Okay. So it was a nicely done what's called randomized phase 3 study. So they took half the patients and put them on placebo or sugar pill and half the patients and put them on sorafenib, because at that time we didn't know, is sorafenib really going to help thyroid cancer or not? And what they found, this is what's called a survival curve. The higher up your line is, the better your survival, meaning the longer, or this is progression-free survival, so not death. This is tumor growth. Okay, so the higher your line is up here, the slower your tumor grew. Okay, so the white here is the placebo, the sugar pill, the yellow is a sorafenib, so it's higher up. So what they showed was sorafenib does basically increase the time it takes for your cancer to grow. So it was growing over at least 12 months before, and now it took 6 months to grow if you were on placebo and almost 11 months if you were on drug. But with that, the FDA approved the drug. We have not proven that it increases overall survival or decreases death. And another drug, which is now called lenvatinib, used to be called E7080, which a phase 3 trial just got completed, and hopefully that'll be published soon. This is a different type of graph that you'll see, and bars going down means there was shrinkage in tumor. So this is another drug that just showed that it had another randomized phase 3 trial of half the patients on the placebo and half the patients on lenvatinib or on the drug, showing that it nicely decreased tumor a lot. So this company is hoping to go for FDA approval for differentiated thyroid cancer as well. So in medullary thyroid cancer, vandetanib has been FDA approved because, again, this is that survival curve I was showing you, not for death, but for tumor shrinkage. The arm up high is better, or longer time for the tumor to grow. So vandetanib, patients who were on vandetanib had a longer time for their cancer to grow. And then the second drug that's FDA approved for medullary thyroid carcinoma is cabozantinib, which, again, this is that other plot I was telling you that when the bars go down, that means there was tumor shrinkage. So these are the 3 drugs. I put the generic name, which is usually what we go by, and the brand name on the right-hand side. So for medullary thyroid cancer, there's 2 drugs FDA approved, vandetanib and cabozantinib. And differentiated thyroid cancer, there's 1 drug, which is sorafenib. All 3 of these are classified as targeted therapies. All 3 of these are also classified as anti-angiogenic inhibitors, meaning they starve the tumor of its blood supply. They attack slightly different proteins that can make the cancer grow, but they also have some common proteins or genes that they attack on the thyroid cancer. So this is a list of some other drugs that are FDA approved for other cancers, but we have tried and we sometimes will use them in patients on thyroid cancer. Even we have those 3 FDA approved drugs, but sometimes patients try it and they can't stand the side effects, or their cancer grows through those drugs, and so therefore they have to go on some other drug. Another drug that you'll be hearing a lot more about is BRAF inhibitor. So for patients who have papillary thyroid cancer, there's a gene called BRAF that can be mutated or changed and help the cancer grow. So thanks to melanoma having the same gene, there are 2 drugs that are FDA approved for melanoma, not for thyroid cancer, that inhibit or stop that protein from growing, called BRAF. So these are currently in clinical trials for thyroid cancer, meaning they're being tested in research. And this is just a picture of one patient who was placed on one of the BRAF inhibitors called vemurafenib. On the left is a PET scan. This is half a body again. This is the brain. It loves PET scans take sugar. We make it radioactive, inject it in the patient, and the sugar will tend to go where there's inflammation, infection, or cancer. Anything that's metabolically active. So this is a patient, this is the neck here and then the chest, and there were some lymph nodes of thyroid cancer that were taking up a lot of sugar, meaning they were active. And then 2 weeks on this drug, you can see there's a nice decrease in the activity under sugar. So suggesting that these drugs may be helpful, but it'll only work in patients who have that BRAF mutation. So it's important to start thinking about, okay, if I have thyroid cancer and I need a drug, I need to get the tumor tested, or have the cancer that they've already taken out tested for different types of genes. So are these therapies effective? Well, they're not cures, okay? They're decreasing time for that. They're making it longer for the cancer to grow. So they're shrinking tumors, but are they really increasing our survival? And that has actually not been proven yet, that while we assume if you're decreasing the tumors, you're shrinking the tumors, you're going to live longer, we have to prove that to be able to say to a patient that this is improving your survival. So that has not been shown in the trials yet, but there's a rumor out that a couple of the drugs in trials may be improving survival, but we have to wait to see the data to be able to tell patients. And there's many side effects, which is why you all are here today, and to hear about what kind of side effects there are. So if you have thyroid cancer, and as the gentleman had mentioned, most thyroid cancer patients don't have symptoms, and then we're going to give you a drug that causes symptoms but may not prolong your life, you want to think carefully before going on the drug, right? So this is a patient with thyroid cancer in the bone of their skull. This is a cross-section, meaning if you're lying down and you slice a picture of the patient's head, the hole here, this is brain, this is normal, but the hole here in the bone is cancer. And this was a patient that when they went on drug, they had a nice shrinkage in their bone. So we do have effects on the thyroid cancer, but this is a slide to show that in one of the trials, in the vandetanib trial in medullary thyroid cancer, these lines look the same. Remember, the orange line was the patients on vandetanib, and the gray line was patients on placebo, and this is a curve looking at lengthening life. And it didn't, in this trial, we have not seen that we lengthened patients' lives. So again, we have to think carefully about choice of drugs, when to start therapy, and who should take the drug. So this is just a list of some of the side effects in thyroid cancer patients, and I'm going to go over them. But just, it can be harsh. And this is just a list of what we're calling the common side effects. And let's go through some of these. This was just a slide that looked at different trials in one of the studies that we did, and I just wanted to pay attention to the line on the bottom. About a quarter of patients have to come off these drugs because they can't stand the side effects. So just something to keep in mind when we're thinking about the side effects, that if it's right time for a patient to go on one of these drugs and we put them on, we need to help manage the side effects. Otherwise, we won't be able to see the benefit, right? So you'll hear the doctors talking about what's called grading of the side effects. Like, how do I call your, rash severe and yours mild? So the National Cancer Institute has come out with a grading scale where the doctor or the nurse, will go through a list of questions with you and says, okay, your diarrhea is a grade 2, your rash is a grade 1, etc. But that's the doctor's interpretation, right? It may be a whole different thing when you ask the patient. So more and more institutions are looking at trying to find what's called patient-reported outcomes. So you grade yourself. How bad is it? Because remember, just like on a pain scale, if you ask somebody 0 to 10, how bad is your pain? This person might say a 2. With that same pain, this person says a 9. Everybody is very different. And so if you have now the doctor or the nurse grading it, we probably will lessen it. And that's what the research is showing, is that we tend to lessen the side effects of what patients are telling us. Now, that could be for 2 reasons. One, you could say, well, the doctor doesn't, fully understand, or the doctor doesn't see that as an important side effect. Or 2, patients don't tell the full story to their doctors because they're afraid the doctor's going to take the drug away, right? So 2 ways to look at everything. So when we talk about some of the side effects, this is a list. I'm sorry, I know it's very tiny. I'm going to tell you the important stuff on this slide. It's on the columns are 4 different drugs that have been looked at in thyroid cancer. And the fatigue, for example, will range anywhere between 15 and 40% of patients on these drugs will say they have fatigue. And something called hand-foot skin reaction, which we'll talk about, like a rash on your hands and feet that can be very painful, can be anywhere from 15 to 30, 40% on these drugs. High blood pressure can occur in up to 35% of patients on these drugs, and diarrhea can occur in up to 50% or 60% of these patients in these drugs. So there are some rare but life-threatening side effects to these drugs, and we'll talk about a couple of them and why they may happen. But fistulas and GI perforation means a hole in your gut. So sometimes when I say AEs on any of these slides, I'm calling adverse events. Adverse events is just another way to say side effects. So sometimes when patients have side effects to these drugs, it's because they're responding to the drug. So in other words, in kidney cancer, for example, they found that all the patients who get high blood pressure from the drug as a side effect, the patients walk in, they didn't have high blood pressure, they get on the drug, they get high blood pressure, now they have to be treated, are the patients who are responding to the drug. So maybe the side effect that a patient is having on these drugs is a sign that they're going to respond. So it may be a good thing. So if we can actually manage and control the side effect, then maybe we can continue the patient on the drug. In some drugs, the skin rash is a sign that you're responding, and these are things that we need to evaluate better in thyroid cancer to say, hey, if a patient with thyroid cancer gets side effect X, Y, or Z, does that mean that they're going to respond, in which case we'll be more aggressive about managing it rather than stopping the drug. So let's talk about individual side effects. So about a third of these drugs will cause skin side effects. But if you go on the specific drug called BRAF or EGFR, again, this is part of the alphabet soup of cancer, if drugs that stop that protein, then it's 90% of those patients will get some sort of a skin rash. So some of these side effects are specific to the drug. You can get different types of drug. You can get itchy, dry skin. You can get a rash. A lot of times if you see a doctor who doesn't treat with these drugs a lot, they'll think that these rashes are an allergic reaction. And then they stop the drug. And you want to be very careful because most of these are not allergic reactions. While there are some allergic reactions, most of what you see, while it can look ugly and look bad, most of them are just a side effect of the drug. Yes?
Is phenylbutyrate one of those that you would get a skin rash from?
Phenylbutyrate?
Yeah. We call it PB.
Yeah, but you can get skin rashes from them, but it doesn't.
Yeah, as in combination with some targeted chemos.
Combination of drugs usually causes more side effects, so it depends on what it's being combined with. Yes.
Would that be an allergy, or would it be one of the side effects of?
So I would need more information. So when my patient calls and says I have a skin rash, I usually tell them email me a picture. Describe it to me, or see your local doctor if it's really that bad. And depending on how bad it is, I'll have them hold the drug. Sometimes I'll walk them through it and tell them what to put on it. So in other words, if it looks like acne, that's specific to its acneiform rash. If it's what's called a macular papular rash, there's spots and dots. This is very typical of the drug, and actually, for example, sorafenib can do this, and it's full body, and it can be red and disturbing, but if you continue the drug and walk them through it and lower dose and hold drug, this will go away.
That's what it looked like.
Oh, okay. So this is one of the more common rashes.
She had melanoma, and she was on about 4 or 5 different drugs, and one of them was, and the doctor took her off of it, thinking that it was
An allergic reaction.
an allergic reaction to
Yeah.
Yeah.
And I'm not saying your friend didn't have an allergic reaction. Again, I wasn't there. I have no idea. So
What was the
my
name of
disclaimer.
that rash?
Macular papular. The macular papular just means spotted and dots. It's just a big term. Paniculitis is something that these are painful. I don't think you can see it very well, but they're raised red bumps that can occur and can be very painful. But again, if you continue drug, these go away, but you have to be able to help the patient through it because it can be very painful. I'm going to show you a couple pictures. I'm sorry if anybody just had a snack or lunch. Okay, I'll show a few gross pictures and then I'm done. This is a picture of hand-foot syndrome, and so you can see the patient has blisters and painful cuts, and so this can be very painful. The first 6 weeks of some of these drugs can be the hardest, but despite continuing the drug, most of these go away, and with proper management, aggressive management. So I tell all my patients when they start these drugs, they either come see me every month for the first 3 months or find a local oncologist, and I'll work with them together, because the hardest time and the time people want to give up are the first 3 months. And if you can hang in there, somehow your body gets used to it. Not used to the pain, but they go away. Okay? This is on the bottom of your feet, and often I have patients see the podiatrist and remove some of these calluses, because the calluses are causing pressure to the point that people can't walk. And often people who use their hands a lot in laborers have the worst hand-foot. And just different degrees of hand-foot syndrome, which can be the most devastating in these drugs. But again, if we manage this properly, it can be fairly well controlled. Urea-based, we tell all our patients, like even our guys who hate using creams and stuff, let's go get some nice ointments. So there's lotions, which are the lightest, right? And then creams, which are heavier. And then there's ointments. And, we got to change lifestyle a little bit. And when we shower, we lather some nice creams and ointments on. Urea-based ones, especially when you get foot, and we give them a list of ones that they can get. And they come in different percentages, and we explain that to the patient. Avoiding sun exposure, long sleeves and hats that have UV protection, not just any long sleeves and hats, and mechanical stress. Some of these drugs can cause precancerous skin lesions, and some of them can actually cause skin cancers, squamous cell cancers. And so seeing a dermatologist early on and helping, usually it's curative to cut them out. Some of them don't need to be cut out, but they can be bothersome. Bless you. Stevens-Johnson syndrome is a life-threatening skin. This is the difference, why it's important that your doctor knows what they're doing, because if you have this, you stop the drug and you don't take this drug. Okay, it's very rare, thankfully, but important in understanding when your patient calls you and say, I have a skin rash, you've got to understand what kind of a skin rash it is, because one, you got to stop drug, and the other ones you just have to manage. Okay, so heart, what happens to the heart with some of these drugs? So high blood pressure or hypertension is the most common side effect for the heart. And basically, remember we talked about vascular endothelial growth factor or VEGF inhibition. So these drugs are starving that tumor of its blood supply. That also causes high blood pressure in a certain percent of people. There's a question in the back. Oh, you were just stretching. Sorry. Okay. Huh? 5 minutes. Okay.
Go over because we didn't start on time.
Okay. So the only thing I wanted to show you on this slide, and I think they're recording this, so I think you'll have access to the slides. So if I go too fast, you'll be able to see the slides. Is that right? Yeah, good. Okay. So all I wanted to show you here was we need to start thinking when we're doing our research in terms of when somebody gets high blood pressure, what's the best blood pressure drug to give you? It's not maybe like normal blood pressure. We need everybody's blood pressure less than 140, the top number, and the bottom number less than 90. To keep us from getting side effects from high blood pressure, like heart attacks and heart failure. So maybe the choice of the drug against the blood pressure works in a better way with chemotherapy X, Y, or Z, but we need to advance our thinking and our research to be able to tell you what's the best drug. Some of the drugs will interfere with the chemotherapy, so that's why you want to make sure your endocrinologist or your oncologist, whoever's managing this, knows that you're starting other drugs that your primary care doctor might have put you on, because some drugs can increase the side effects of other drugs. So it's important that your list of drugs every time is updated, including supplements, including over-the-counter stuffs and herbal meds. Don't be afraid to tell your doctor you're on them, because some of them together will increase toxicity or side effects. Your doctors should be getting EKGs or on your heart, because this is just a picture of what the beat of your heart looks like. This thin, tall part in the center can get longer, or what's called QT prolongation, which is something you see on the EKG, but it can lead to sudden death. So this is something your doctors are monitoring, and specifically with one of the drugs, vandetanib, there's a black box warning that says you have to get EKGs every month for the first 3 months, and it explains, 2 to 4 weeks. There's an explanation of black box warning. So important that all these things are followed upon, because these are things you can prevent: lower dose, hold drug, change drug, all these things that we need to be aware of. So what about kidney problems? Kidneys can leak urine. That's what's called proteinuria, and you can get all these other fancy names for side effects, but basically it says that your kidneys aren't working well, and we need to probably hold drug, stop drug, or figure out if there's something else causing that. What about gastrointestinal or mouth and gut problems? So one of the more common side effects is diarrhea. And people can have decreased appetite and some nausea, and it's important to manage these early on. One of the more life-threatening ones that I told you we'd talk a little bit about is what's called a GI fistula, and that's when the gut normally should just be connected then and everything comes out the other end. Well, if you get a hole between your belly compartment and the gut, then you have bad stuff leaking where it shouldn't. And that obviously can be life-threatening. So important to, you have belly pain, you have symptoms, tell the doctor. It's very, very rare, but important that people understand that it can happen, so it's things to look out for. If people have diarrhea, we don't tell them, there's nothing preventative that we can do. We don't know why some people get diarrhea and others don't. And so if you do develop diarrhea, then we may look at a change in your food habits and look at your food diary. And in some people that helps, and in others that doesn't. We will sometimes give Lomotil or Imodium, opium. There's different drugs that we can try. Metamucil, interestingly, mixed in a certain way with water, can help. One of our colleagues at MD Anderson, Dr. Ramona Dadu, is looking, there's a capsule that has clay, like literally clay in a capsule, that they had looked at for diarrhea from colon cancer, and I guess it didn't take off for whatever reason. Dr. Dadu said, hey, I want to try patients who have medullary thyroid cancer who get bad diarrhea, even not on chemo, okay? And she tried that in a subset of patients with diarrhea, and the preliminary results are showing that it's very promising. And actually, a lot of the patients were at ThyCa and started blogging on ThyCa. If you have medullary thyroid cancer and diarrhea, go get Kasad. That's the name of the clay. So now her next interest is to say, hey, if we can help patients with medullary thyroid cancer, and she's working with the company to see how they can take that forward. What about patients who are on these drugs that cause diarrhea, and can CASAD help that without blocking the medication or stopping the chemo from working? So with diarrhea, we have several drugs that we can try. Patients also can lose weight on these drugs and become anorectic and have decreased appetite. And remember, they were asymptomatic from their thyroid cancer in some cases. In some cases, they had symptoms from their thyroid cancer. And so we have to be able to manage these side effects and listen to the patient when they're telling us they're having these side effects so we can treat them. And nausea and vomiting. You can get ulcers in your mouth or redness or irritation in your mouth. Again, most of that is short-lived but needs to be aggressively managed so patients don't stop eating. And one of my fellows at, I'll get your question in a second. One of my fellows at MD Anderson, Dr. Lalikwa Tampura, was sitting with us in clinic, and she said, hey, these patients on these drugs, I'm seeing a high percentage of them lose weight. And is it just from the diarrhea or the mucositis, the inflammation of the mouth, or the decreased appetite, or could the drug itself, with its VEGF or these pathways that it inhibits, could those directly be causing weight and muscle loss? So she's actually doing a study now to try and see why patients are losing weight, and if we aggressively manage the diarrhea and the weight loss and the appetite, etc., are they still losing weight, and how can we prevent that? Because those may be the patients that are responding to the drug, but again, we don't want them losing weight and muscle. You had a question? Wow.
It's from New Zealand, and we ordered it on Amazon.
Very cool. Something to add to my list and look up.
Yeah.
Yes?
Where can one send their old thyroid to have it tested for BRAF?
Good question, and I will come to that if you remind me right at the end. Okay. So again, fistula formation is rare but life-threatening, and that's any abnormal connection between two organs that should not be connected. And what we started seeing with some of these tyrosine kinase inhibitors, especially in patients who are at higher risk, have thinner skin, or have had radiation to their neck, the breathing pipe called the trachea and the food pipe, the esophagus, can have a life-threatening connection. So again, it's very rare, but something that doctors need to be aware of. And so we wrote this up because we were seeing that it wasn't reported very often in the literature, but surely we could not have been the first ones to see it. Bleeding from your gut. Anytime you have red stools, black stools, vomiting blood, this is an emergency. Go to the emergency room and then call your doctor. Rare, thankfully. And briefly, a lot of you will need, or a lot of people who go on targeted therapies will need an increase in their thyroid hormone, and we're not, there's some data that it increases decreases the absorption of the thyroid hormone, and some data that it may be getting rid of it faster. So depending on the drug that you're on, your thyroid blood tests need to be followed closely, which they typically are in the thyroid cancer patient. Blood counts need to be watched. And then fatigue, which sometimes is downplayed in a lot of these trials, but if you talk to the patient, you have to help them through it. And so encouraging a 2 p.m. nap, encouraging exercise, and other things that battle fatigue. There's a couple of people that have recognized some of the life-threatening side effects from this, and it has been published, so that's really nice. And this is my last couple of slides. So how do we think about side effect profile? How do we, not everybody's getting these side effects. I will tell you that most of my patients go through these drugs. Maybe with some of them it's a little bit rough the first month, but most of them continue to work, continue to do everything normally. And I have some patients who come and tell me, are you sure you're not giving me placebo or sugar pill? So by giving you all this information, I'm not trying to tell you that these drugs are dangerous, toxic, say no to them always, because I know it sounds scary. What I'm trying to say is that it's important to figure out when is the right time to start it. You don't know if you're going to be the person who has these side effects. Most of these side effects are managed fine in the right hands. And sometimes, if you can't take the drug, you can try something else or have that discussion with the physician. So, and sometimes when you have these side effects, it means that your tumor is going to shrink. So it's just important to be aggressive about managing the side effects. But I can tell you that most of my patients do just fine and continue to work, and or if they're retired, continue to do their fun life. So it's not like it's stopping all life, etc. And so we need to think about personalized medicine in the real way. Who's the right patient to start the drug? What's the right dose in that patient with the least side effects? And when's the right time to actually start the drug? Because if we think about it and we're not curing people, we're hoping that we're prolonging life and shrinking the tumor, but it's important to understand who that patient should be, that should be started on. So some of these are just some websites to look up if people are interested in getting on a clinical trial for a friend or other people. And then on the bottom are just some information on more information on targeted therapies in addition to the websites above. And even though my kids tell me not to go to Wikipedia, I actually found some good information. So whoever's writing it on there. All right. So with that, I want to acknowledge my patients, because none of this would be possible without my awesome patients who keep me going every day. And then the multidisciplinary team that makes this happen. So this is not just one doc doing this. This is a group effort. We discuss all our patients. What's the best way? This patient has thyroid cancer back in their neck for the 4th time. Should we do surgery, or should we think about something more novel, like give them a short dose of chemotherapy, what's called neoadjuvant, and then take them to surgery when it shrinks so it's less morbid surgery? Do we radiate this patient? Do we just treat the thyroid cancer that's gone to the bone or to the brain individually and not think about, systemic drugs or targeted therapies and things like that? And thank you to ThyCa and our patients for making this possible. And I've just put my email if anybody has any questions up there, and the new patient endocrine office at MD Anderson. Yes. Yes. Yeah. Okay. So thank you for reminding me. The question that had come up is, how do we get our tumors tested for BRAF or any other genes? So sometimes the doctor that you go to has access to a lab to order the testing. It's not something you as an individual can order, but you can talk to your doctor about it. So some hospitals have it. So for example, at MD Anderson, we talk to a patient about it, pros and cons of doing it and what information we might get out of it. And there's a few tests that insurance companies will pay for, and it's called a panel of genes. And so it depends if the literature shows that this gene does show that this cancer might grow faster, or this gene, we have a drug that can attack this gene. So there's a list of genes that can be checked for. So what we do at MD Anderson is it's standard to get what's called a 50-gene panel. It's called CMS 50, where we look for 50 genes. Not all 50 genes are found in thyroid cancer, but it's easier on certain machines to check all 50 than it is just to check the 3 that you're interested for thyroid cancer. So we get some information there. And then we have several research trials, not to be on a drug, but where the patient says, well, I did this 50-gene panel and we didn't find anything, so let's expand this to the 400-gene panel to look for something that, I'm going to need a treatment 6 months from now or a year from now from what the way my thyroid cancer has been going, and I want to look more. If you're not a patient at MD Anderson, you can, or your doctor can have your pathology tissue, which is the cancer that has been removed and sitting in the lab. It can be sent to MD Anderson. There's an order form on mdanderson.org to click and order it and have it sent without you having to come down to Anderson. Other institutions around the country that you may be living closer to may also have it too, so worth inquiring. And then if they don't have it, definitely contact one of us. Yes?
I want to go back to what you were talking about with RA, and you said toxic levels. What's your definition of a toxic level of RAI?
There is no definition of a toxic level. So some patients can, the question was, what's my definition of a toxic level of radioactive iodine? I'm not sure I used that term, but I'm sorry if I did. There is not a toxic level for radioactive iodine. Oh, high dose, yes. Okay. So there's a couple of trials, randomized trials, that have looked at, patients with similar size tumors, similar lymph node involvements. If we use radioactive iodine at a low dose versus a high dose, do we get the same outcomes, meaning the same decreased risk of the thyroid cancer coming back or decreased risk of death? The trials just answered, is there any evidence of disease after the radioactive iodine by thyroglobulin and or ultrasound, depending on the trial. They weren't answering if you have, fewer deaths, etc. And what they found was lower dose is just as good as a high dose. And so maybe we should be thinking about lower doses. The science, unfortunately, of dosing of radioactive iodine is not anywhere near what you would want it to be. So it's not a perfect thing. It's not like you measure in your body, you can tolerate X number of millicuries without dropping your blood counts, etc. There are ways to do that. It's called dosimetry. Most institutions do not use that. Or you specifically have to request it at an institution to get it because it's labor intensive and very expensive. And for a low dose for a one-time treatment, it may not matter, but when you're getting multiple treatments, it would matter. And so there isn't this is the highest radioactive iodine dose you can get, but the higher your dose, the potential for more toxicities. And so that's what I meant to say. I'm not sure what I said earlier. Yes, sir.
So if you start...
Oh, I'm sorry. Before you ask that, because our time is up, I will not be offended if you walk out of here at all, and I won't find you rude. So, okay. Because you have to be on time.
If you start on one of these targeted therapies... Sorry, I'm post-external beam. If you start on one of these targeted therapies, such as Nexavar, do you ever come off of it?
Yeah, it's a good question. So basically with the targeted therapies, it's different from a lot of the cytotoxic chemotherapies that you're used to, where you hear the patient takes it for 4 months, every 3 weeks for 4 months or 6 months or whatever it is. With some of the targeted therapies, you take it as long as you can, you're doing well from a side effect standpoint, and that your tumors are either shrinking or remaining stable. So patients who have their thyroid cancer growing, if you get on these targeted therapies and we halt it or can stop it from growing, it remains stable and you're doing well and asymptomatic or having low number of symptoms, then you continue on that drug. What we've found in some of these drugs, by year 2, 2.5, 3, your tumor has become smart and found a new way around it, or made new genes that we are not attacking, so what's called acquired resistance. But there are patients on some of these other drugs for over 5 years. So sometimes we talk with patients, depending on their side effect profile, should we take a drug holiday and then get back on it? Should we go to a lower dose? And it's important when we think about long-term therapies, are we going to come off it? It's not that if once you commit to the drug, you have to stay on it. It's always a consenting thing. You have the discussion with your physician. Can I stand it? Can I not? Is it really helping me? What will happen if I take 2 or 3 months off? Can we just see what happens on the CT scans and on the blood work? And if I'm doing okay, maybe it's time for a holiday and we've held things steady. So those are important discussions to have. Yes?
When I had my radioactive iodine, it burned my underarms, so I don't sweat under my arms anymore. Will that come back? Can that be healed?
So
5 years ago.
That's something that is very, very rare. So most of the time, these side effects, like when sometimes patients will come and tell me that, 20 years ago when I got radioactive iodine, my teeth basically started falling out. And that's, again, something that's not described. But I take all my patients seriously because obviously something's changed since somebody's put something in their body. Now, what I can say is with radioactive iodine, the way it works is it's iodine because, the thyroid likes to use iodine to make thyroid hormone, but you're making it radioactive, so it's local radiation delivered. So typically, like for example, in the salivary glands, when you lose your saliva, it's scarred. So saliva's not coming back. So I would guess sweat's not coming back, but actually I would celebrate that, or no? As a woman.
It does make you very hot.
Oh, it does? So you make
cool
it
off.
makes...
You don't cool off as efficiently as you could.
Okay. So you notice it in your life. That's unfortunate. Huh?
Always a downside.
They are, I know. All right. Thank you so much, guys. Good luck. Go for the cure.